Hi, my name is Katie Gudiksen, and I'm excited to talk to you today about state efforts to address healthcare consolidation and healthcare costs. I work at The Source on healthcare price and competition, which is an independent project at UC Hastings Law School in San Francisco. I'm sure many of you are familiar with Hastings, but I wanted to give you just a quick bit of information on The Source because I hope there's a lot of information there that y'all might find helpful. So the Source on healthcare price and competition is a website, and we have all kinds of different monthly blog posts, reports, analysis of news reports, curated news reports, maps and interactive features, and also academic articles. What I think might be most interesting to many of you is that we've created, in partnership with Catalyst for Payment Reform, we've created this database of state laws impacting healthcare costs and quality. We call it the SLIC database. And it has bills and laws from all 50 states with covering many different aspects of healthcare price and competition, including price transparency, payment reform and benefit designs, ways to control and encourage provider competition, and then oversight and regulation of costs, single payer bills, all kinds of things. If you're interested in more information on anything I talk about or to look up specific language in bills, you can come here. This website is free and fully searchable, and lots more information about the things I talk about will be here. In addition to the database, we have a number of interactive features. The one I'm showing you here is on market consolidation, but we also have them on provider contracting and other things that this group may find interesting. And you can click on any state and get more information about the laws in that state or cases that have been in that state. And just look at the variation about what states are doing to address rising healthcare costs and consolidation. So why do we do this work? Why do we spend the time and the money to create all these resources? And to get some perspective on just how big a problem healthcare costs are, I want to begin with the question, what if food items increased like the cost of healthcare? So if prices for food increased like healthcare costs did between 1945 and 2009, the price of a dozen oranges would be $48. The price of a dozen eggs would be $55. And a gallon of milk would cost a whopping $134. When viewed this way, it's clear that healthcare costs are pretty outrageous. And this is a problem for Indiana too. It's not just a national problem. And you can see here from 1997 to 2017, personal expenditures on healthcare related services grew much more rapidly than for all non-healthcare services or other services. So why are healthcare costs so high and why are they increasing? It's prices. As you can see here in all the categories listed except cataract surgery, the US has higher medical prices than any other country studied. Prices are the primary reason why the US spends more on healthcare than any other country. It's not because we use more or have higher quality, it's simply because we pay more for the services that we get. So what happened to make US healthcare prices so out of whack? And I think it boils down to three failures. A failure to protect the free market system, essentially a lack of price transparency. The second failure is failure to protect competition and rigorously enforce antitrust laws. And the third is a failure of policymakers to act when the free market system simply no longer works and where competition isn't enough to keep prices in check. So I'm going to take these one at a time. And the first failure is the failure to protect price transparency. And this failure is very evident for patients, with nearly 2/3 saying it's difficult to find out what medical care will cost and many receiving surprise bills. But transparency is much more than consumers shopping for care. A lack of transparency doesn't allow policymakers to understand when the markets aren't working and doesn't allow employers to develop cost-saving measures like centers of excellence or reference pricing to encourage employees to get higher value care. In the latest state price transparency report card that was issued in March, you can see that Indiana, like much of the country, gets a failing grade. But in this case, I have good news for Indiana. The past legislative session, there were one law with two provisions to greatly increase transparency in the state. And the first was to remove gag clauses that used to prohibit patients or employers from getting information from their providers or insurers about what healthcare was going to cost. And those gag clauses have now been prohibited. The second is to create an all-payer claims database that will warehouse paid claims in the state of Indiana. And when it's fully implemented, it'll allow policymakers, the public, employers, and researchers to get information about how healthcare markets are functioning in the state, to target interventions, and then to assess whether any of those policy changes have really made a difference for the residents of Indiana. The second failure is a failure to protect competition. So from 1991 to 2011, the FTC did not win a single case trying to block a hospital merger. And this did two things. It caused the FTC to back off on enforcement efforts in healthcare and focus their resources elsewhere. And it also encouraged more hospitals to merge and increased consolidation dramatically. As you can see here, the Herfindahl-Hirschman Index, which is a measure of consolidation, increased continuously from 1987 to 2016. And now, over 95% of the metropolitan statistical areas in this country have highly consolidated hospital markets. And it's not just hospitals. As you can see over this same time period from 2010 to 2018, insurers consolidated and physicians, especially primary care physicians, merged and consolidated. And what is the effect of all this consolidation? A healthcare merger mania. Study after study demonstrates that consolidation drives much of the increase in healthcare prices. In this talk, I'm going to talk about three types of consolidation. The first is horizontal mergers between two hospitals or two physician practices in the same market. Basically, hospitals or physician practices that would see similar patients, see patients in the same market. Vertical mergers, that's when a health system or a hospital acquires a physician group. And cross-market mergers, and this would be a merger between say an urban health system and a rural hospital. And when I say mergers, I don't just mean mergers with a change of ownership. I also mean any kind of affiliation agreement, joint ventures, private equity, consolidation, etc. So what's the evidence tell us about what happens following one of these mergers? First, when we talk about horizontal mergers, we're talking about two companies in the same industry merging together. So two hospitals or two cardiac specialty practices, for example. And in these instances, studies have shown that prices increase, quality was reduced, premiums go up, wage growth is reduced for hospital staff, and also higher costs. The hospitals in larger systems have higher operating costs than in smaller systems. For vertical mergers, these are when a hospital acquires a physician practice. Studies have also shown that physician prices increase, cardiologist prices, and orthopedist prices increase. Also, clinic prices go up and hospital prices go up with little to no quality improvements. Additionally, federal antitrust officials have generally not reviewed vertical mergers, or when they did, found mergers not anti-competitive. And part of this reason is that federal law exempts transactions under a certain size from having to report proposed mergers to the FTC. So the Hart-Scott-Rodino threshold, which is what this is called, was $94 million in 2020. And that allows health systems to acquire most physician practices essentially unnoticed. And this leads to stealth consolidation, where a health system can buy up individual physician practices that on their own might not be so concerning. But when you buy up, for example, all the orthopedists in a market, that should generate antitrust concerns. The third type of merger that I want to talk about are cross-market mergers. And this is a merger that policymakers should eye much more closely. Economic theory says that since there's no competition for patients, there should be no anti-competitive effects. But as Dan talked about, when a hospital system acquires a rural hospital that is essentially a monopoly in that market, that rural hospital has must-have status. They can't put together a contract without it. And if the health system uses contract provisions that distribute that negotiating power across the whole system, it can drive up prices. And that's exactly what the research tells us. Following a cross-market merger, hospital prices increased when purchased by an out-of-market hospital system. But not only that, competing hospitals also increased their prices and costs throughout the system went up. So what's the evidence that this might be happening in Indiana as well? Does Indiana have a problem with all of these mergers? And the answer is yes. A qualitative study by researchers at Georgetown University found that all three types of mergers are happening in the Indianapolis market. For horizontal mergers, they found that each of the large four health systems essentially carved out geographic mini monopolies and respected each other's boundaries. So within each system, they could charge higher prices within those markets. Second, for vertical mergers, researchers found that Indiana had aggressive competition between the health systems to acquire physician practices before another system could do so. And respondents estimated that 80% of physicians were employed by the health systems. So what does this mean for costs? If a hospital-employed physician has to refer his or her patient for an MRI, they're much more likely to refer that patient within the system rather than to a lower cost freestanding MRI clinic, for example. And that drives up costs throughout the system. Finally, the third type of merger, cross-market mergers, the researchers also found evidence of this happening in Indiana. Specifically, they found that acquisitions of Indiana hospitals outside the Indianapolis metropolitan region were strategic, and communities that had essentially a hospital monopoly or a rural area where there was only one hospital were targeted and then used to negotiate targeting contracts, which distributed the negotiating power or the must-have status of that one hospital throughout the whole health system. And these mergers, there's evidence that it does drive up prices in Indiana. In the most concentrated market, where there's roughly 0.112 unaffiliated hospitals per 100,000 residents, the average cost of a measured outpatient services was 4 times what Medicare pays. Even in competitive markets, where there were roughly 2.25 hospitals per 100,000 residents, on average, insurers were paying double what Medicare pays for those same services. So what can be done? We at The Source just finished a 50-state survey reviewing state merger review practices across all 50 states and pulled out best practices to give recommendations to other states who are seeking to improve their merger review process to minimize the impact of any competitive mergers and to find out about them in the stealth consolidation before they happen. We group our recommendations into 4 categories: notice review, the approval process, and post-transaction monitoring. Perhaps the most important of these is notice. So the AG cannot oppose any merger that they don't know about. So if they have to read about it in the newspaper after it happens, it's much more difficult for them to go to court and ask a judge to unwind a merger that's already happened, as opposed to becoming aware of mergers before they happen and perhaps imposing consent decrees that put conditions on that merger. So within notice, we suggest a broad scope of entities: hospitals, physicians, clinics, et cetera. And an individual acquisition of a physician group might not be problematic, but getting notice allows the AG to track these acquisitions over time and identify them when they might become a problem. So if a health system is buying their 20th physician practice in a given market, the AG could be aware of it. So the acquisition of that small practice group might not, in general, raise antitrust concerns until there's evidence of this stealth consolidation. We also recommend that there be a broad scope of transactions. So it's not just a complete change of ownership, but essentially affiliations and any material change must be reported. And also in notice, we suggest a waiting period so that the AG or any state agency is given time to review the proposed merger before it's consummated. During that review process, we suggest that there be substantive review criteria so that the AG be allowed to consider competition, what the impact on affordability or prices would be, and essentially whether that merger is in the public interest. We also suggest that there could be a tiered level of review. So for individual physician practices, the review would mostly be just tracking that it's happened, whereas a merger of 2 large health systems, for example, would definitely trigger substantive review at the AG level. And similarly, during the approval process, we suggest that this tiered level of review could result in tacit or actual approval. So for example, for most physician practices that are small, if the AG chooses not to undergo a full review, there could just be tacit approval after the waiting period has expired. But during that period, if the AG wanted to step in, they would have the chance to do so. And finally, we suggest post-transaction monitoring. So if any even potentially concerning merger is allowed to go through, we suggest that those mergers undergo a monitoring process where the monitor is paid for by the merging entities to track what happens to prices or access quality during the period post-merger, and to require annual compliance reports. So what does Indiana's merger review look like? Well, the provider merger review could use some work in Indiana, frankly. The AG has only currently received mergers of nonprofit hospitals. So for-profit entities can merge without giving notice to the AG. And in that, after the notice, the AG is not required to act. And the review doesn't necessarily include any kind of health access, pricing, or competition standards for the AG. So this is an area where the review process could be greatly improved by legislation. For example, SB 977 in California, a proposed bill that is currently before the Assembly, would incorporate many of these changes, and there's some language there that Indiana could consider adopting, and there is broad notice required to the AG and an approval period in that bill. So this is one recommendation I would make for Indiana to improve the merger review process for provider mergers, for all provider mergers. But unfortunately, in many markets, the train has left the station. Well, just like in medicine, preventative care is best. What can we do now that consolidation is a fact of life in many markets? Well, competitive markets need support. And we've identified 3 pillars that we suggest states consider or policymakers consider when trying to give competitive markets support. And I would say that these pillars support each other. They're not mutually exclusive, and all 3 of them are important in competitive markets. That's litigation, legislation, and regulatory oversight. I'm going to take these one at a time, but again, they're not completely independent. So the use of litigation to address anti-competitive contracting, I'm going to talk about 3 major lawsuits to address anti-competitive contracting practices by dominant firms. So the first is Blue Cross Blue Shield in Michigan, and the DOJ and the Michigan AG filed suit alleging that Blue Cross Blue Shield used most favored nation clauses in both exclusionary and collusive ways. And what do I mean by that? So a most favored nation clause is a guarantee that a buyer of services, essentially an insurer, receives the best terms, or at least equivalent terms, to any other buyer from a seller, from a hospital or a provider. And in Michigan, Blue Cross Blue Shield was a dominant insurer, and it would go to a hospital, allegedly go to a hospital, and ask that no other insurer be given better terms. And what does this mean for the hospital? Well, if a competitive insurer came and offered a lower price to that hospital, for example, if that second insurer was trying to offer a narrow network so the provider would get many more patients, that's a case where providers often would negotiate a lower rate because they have an increase in patients. But that hospital would know they'd have to pass that lower rate on to Blue Cross Blue Shield or the insurer with the MFN. And so that hospital is unlikely to offer that to the first insurer, which means that basically it's exclusionary, that Blue Cross Blue Shield has found a way to keep other insurers out of the market, even if they're offering a different kind of insurance. And second, because the hospital knows that Blue Cross Blue Shield is getting a benefit from this MFN, they can raise their prices a little bit. So they can say, I'm going to charge you even a slightly higher rate, but I will sign this MFN, but I'm going to charge you a slightly higher rate. And Blue Cross Blue Shield is happy to sign that because they know that any other insurer in the market is going to get that same price increase, and all the insurers will have to pass that price increase on to employers and patients. And so Blue Cross Blue Shield there's not any inconvenience to them, there's not any risk of losing market share. And so what this means is that providers and insurers, hospital systems and insurers, basically both benefit when prices go up. And the only people who may be hurt are the people who actually pay the bill, the patients and the employers. So this case was dropped after Michigan passed a law banning the use of MFNs in all healthcare contracts. The second case, the DOJ and the AG of North Carolina filed suit against Atrium, which was allegedly using steering contracts, anti-steering provisions that prevented other health systems from being on better tiers, or for allowing patients or employers from even knowing that Atrium had much higher rates, and from steering patients to other providers. And the third case that Dan talked a little bit was about Sutter, where the Union of Food Workers and Employers Benefit Trust filed lawsuit against Sutter Health, and this lawsuit was joined by the AG. And in this lawsuit, they alleged that sort of a monopoly broth of terms, so all or nothing contracting, high out of network costs, anti-tiering, anti-steering provisions, and gag clauses were all used collectively to demand super competitive prices. And both Atrium and Sutter both ended in settlements. The Sutter settlement is still pending, but there was a preliminary settlement in which both Atrium and Sutter agreed to injunctive relief, where they agreed not to use those concerning contract terms anymore. So what are the benefits and drawbacks of using litigation? So first, when you use litigation, it can be used on a very case-specific basis. So it can be, was there actual harm in this case, and to show that, to demonstrate that harm. But it can also have market-wide effects. So once another health system realizes that the DOJ or AG are looking out for anti-steering terms, other health systems may be unlikely to use those as well. They can be brought by private parties. The public doesn't have to wait for antitrust enforcers or the state legislature to act, and private parties can get triple the damages that they demonstrate happened from the anti-competitive loss behavior. And finally, they can demonstrate harm from new contract provisions or the use of contract provisions in conjunction with each other. The drawbacks, of course, are these cases are resource intensive. The cases can take many years. The Sutter lawsuit was filed in 2014 and it still hasn't reached its final resolution. The case-by-case enforcement doesn't assure widespread compliance, so another health system could still use anti-tiering, anti-steering until the antitrust enforcers come knocking. And finally, there's some legal uncertainties. So proving things or defining the market definition can be very complicated to prove in court, and it can often come down to the competing testimony of dueling economists. So we see antitrust enforcement as a way to seed other interventions. So litigation should supplement good legislation. Litigation is precise, but it's also costly and time consuming, and it denies immediate relief for the public. So one can think of legislation as sort of an all-encompassing automatic farming, like the irrigation system here, but litigation as a farmer remedying the issue of, say, a single plant. So while litigation can be a template to remedy many of the issues we've been talking about today, it doesn't always resolve issues in a timely fashion. So the use of legislation is another pillar that's necessary to support competitive markets. And legislators may consider prohibiting the use of a specific contract term, so very specifically anti-tiering or anti-steering terms. They may also declare use of certain contract terms presumptively illegal when they're used by firms with market power. And the statute, they can define market power in the statute, so a certain percentage of market share, for example. This again is being used in SB 977 in California, or is being proposed in that bill. That would make tying and exclusive contracts presumptively illegal when used by firms with market power. And a third use of legislation may be to require the insurance commissioner to approve contracts with specific terms. So for example, if a contract between a provider and an insurer contained an anti-tiering or anti-steering clause, the legislature could require the insurer to review that contract and issue his approval before that contract is used by the provider and the insurer. So I'm going to talk very specifically about three types of legislation or three contract terms that some state legislatures have banned for use in the state in healthcare contracts. The first is anti-tiering or anti-steering clauses. Dan talked about these, so I'll be very brief. But in these cases, a higher price provider or a dominant provider will require insurers to put them on the preferred tier or the lowest cost sharing tier, no matter what their cost or quality might be. And Massachusetts has passed a law requiring, basically restricting anti-tiering or anti-steering contract provisions. And New York and New Jersey are currently considering bills to do the same thing. So these are the contract provisions that were the subject of the Atrium case in North Carolina and the Sutter case in California. In addition to banning the anti-tiering or anti-steering contract provisions, Massachusetts also, in that same law, requires insurers to offer tiered or narrow network products in some markets to be in the state. So not only did they restrict the practice, they also promoted the use of tiered and narrow networks, recognizing that they can be a meaningful way to promote cost savings and quality. The second contract term, specific contract term that I want to talk about, is all or nothing or affiliate contracting. And so in this way, Dan also talked about these, but to review, in all or nothing contracting, a health system may use a must-have provider. So say a hospital in their system in a rural market where that's the only option for that community, and tie it to other products. So if you want to use our health system, if you want to contract with anyone in our health system, you have to also include that. If you want to include that one rural hospital in your network, you have to include other members of our health system. And what that does is it drives up prices across the board, because insurers aren't really able to steer or negotiate better pricing for that rural facility that's a must-have in their network. And that allows them to spread that negotiating power throughout the system, even in markets that look relatively competitive. So only one state, Massachusetts, has restricted all or nothing contract provisions, and those restrictions are only in tiered or narrow network plans. So it's not a broad all or nothing prohibition. New York and Colorado are looking at much broader restrictions on all or nothing contract provisions. And as I said, California's SB 977 is attempting to, it puts its finger on the scale for antitrust lawsuits and basically declares any kind of tying presumptively illegal by health systems with market power. The third type of state law that, in fact, many more states have banned are most favored nation clauses. And in this case, Indiana is also a leader, like they have been in price transparency or in gag clauses. And it was one of the earlier states to ban most favored nation clauses. There are 17 states that ban most favored nation clauses. And I also wanted to point out that in this case, New York has a law where their insurance commissioner must review contracts with MFNs. So MFNs trigger a material change standard for contracts that the insurance commissioner must then review before they are implemented. So if an insurer and a hospital system want to sign a most favored nation clause, it must be approved by the insurance commissioner. And that way, if two non-dominant systems wanted to use an MFN for some pro-competitive reasons, they could make that case to the insurance commissioner and he or she could approve it. But in general, the insurance commissioner could be looking at these and making sure that they are not used in any competitive ways by large participants to drive up costs in the state. So like litigation, legislation has its own benefits and drawbacks. So the first benefit is that it's an industry-wide regulation. Nobody looks like they're playing favorites and everybody must abide by the same rules. It also doesn't require any fact-specific determination of market power by economic experts or any of the difficulties in proving an antitrust case. And similarly, it eases the burden on antitrust enforcers and reduces required resources for enforcement. The drawbacks are that provisions, contract provisions or contract terms are not contracting practices. So dominant firms may be able to get around these legislative prohibitions with other alternate kinds of arrangements, or even a wink and a nod and a handshake. So specifically in Indiana, a 2011 health affairs paper suggests that insurers in Indiana may still be able to exert their market power to mimic the effects of a most favored nation clause, even if there's no apparent MFN in the contracts themselves. In addition, legislation requires action by the state legislature for every single term that they want to ban. And in this sense, it can feel like a game of whack-a-mole between the legal teams and dominant firms and the legislature or the legislative process. Which brings me to the third support for competitive markets, and this is regulatory oversight. So in this sense, it's a proactive approach. We're suggesting that some regulatory agency take a look at all the contracting procedures or contract terms in the market. So someone is tracking and analyzing what's happening in healthcare markets and contracting and prices. The classic example of this is the Health Policy Commission in Massachusetts, which reviews the contracts and mergers and really looks at what's happening in healthcare markets in the state. So are prices going up? Is there cost shifting to the private insurance market? And the HPC issues annual reports about the state of healthcare in the state. But if a state doesn't have the resources or even the political will to create a health policy commission to really rethink the way healthcare is done in the state, they can rely on agencies that already exist. So for example, the insurance commissioner and the attorney general both already are used to analyzing contracts and specific practices in the state. So a state legislature could grant additional authority to the insurance commissioner or attorney general so that they get more information about contracting practices, and then can intervene if there are any concerning practices. So this review can also be somewhat automatic. So there can be triggered responses. For example, if rates increase more than a given amount, or even if there are rates in the contract that are, for example, 4 times that of what Medicare would be paying for similar services, that can trigger further review or automatic requests for more information from the insurance commissioner or the attorney general. So again, these types of regulatory oversight have benefits and drawbacks as well. So the benefit is that it's proactive. So you're not looking for concerning behavior, rather you're monitoring what's happening in the market. And there's coordinated oversight so that you can see if prices are going up and to see what contracting practices might be rather than just contract terms. It also can work with existing agencies and processes. So even if you need additional authority, these are agencies that already exist, or at least can be agencies that already exist and are used to looking and have expertise that's used to looking to these markets. The drawbacks are that the enforcement may vary depending on the administration or the political bent, or whether your insurance commissioner or attorney general are elected or appointed, those sorts of things. So they can be somewhat subject to political processes. But again, if you have automatic triggers of price increases or prices, that kind of thing, it can trigger additional review. And that can minimize any agency capture type of concern. In addition, the implementation will require financial support. So even if you're not creating a whole new commission, you will probably be requiring additional staffing in the insurance commissioner or AG's office. And in addition, the scope of oversight or contracts, especially if it's with the insurance commissioner, will be contracts that are regulated by the state. And so self-funded employers may not benefit from this review, but at the same time, if it improves the function of the healthcare markets in the state, self-funded employers will reap those benefits from contracting practices and prices that they see elsewhere. So just to reiterate, there are 3 pillars that support competitive markets, and these work together. There's cross-fertilization and support from each of these. For example, the regulatory oversight may identify legislation or concerning terms that should be banned or prohibited completely by legislation. Or if the regulatory oversight is done by the insurance commissioner, they can identify particularly problematic or concerning actions in the market and pass those, notify the attorney general for additional action or review. So with the highly concentrated markets that exist in Indiana and across the country, none of these tools can work alone. And states including Indiana, need to improve all three to really address the problem of healthcare competition, which leads me to some very specific recommendations for the state of Indiana. First, I would recommend enhancing the merger review process, especially for provider mergers. Second, I would suggest using legislation to address all or nothing or affiliate contracting and anti-tiering, anti-steering contract provisions. These are two of the contract provisions that have the highest potential for anti-competitive behavior and very few pro-competitive justifications, especially in concentrated markets. If there's any concern about losing some pro-competitive benefits, you could consider allowing the insurance commissioner to grant a waiver process or something for firms that do not have market power. Third, I would suggest giving the insurance commissioner additional authority to review contracts, all contracts, and pass any with concerning provisions to the AG for review, and triggering additional automatic requests for information if rates or rate increases seem excessive. And finally, you could consider making rate caps as a backstop for when markets are not working. So Rhode Island, the insurance commissioner there, if rates increase higher than the consumer price index urban plus 1.5%, then there's an additional review process where the insurance commissioner really takes a deep dive into the contracts. And something like that could provide additional oversight or help decrease rate increases in the state of Indiana. Thank you. For more information, you can check out the source on healthcare price and competition. The website's there, and I'm also happy to answer any questions by email. Thank you very much.